So I'm Dr. Alice Liang. I'll be moderating the rounds today, and we are appreciative, as always, with the Office of Lifelong Learning, or L3, who helps with a lot of the logistical supports for these rounds. The territorial acknowledgement. The University of Alberta, its buildings, labs, and research stations are primarily located on the territory of the Cree, Blackfoot, Métis, Stoney, Dene, Iroquois, Ojibwe, Saulteaux lands that are now known as part of Treaties 6, 7, and 8 and homeland of the Métis. The University of Alberta respects the sovereignty, lands, histories, languages, knowledge systems, and cultures of all First Nations, Métis, and Inuit nations. So use the Q&A for questions and use the chat feature about technical issues. So now I'd like to introduce you to our speakers. So we have two speakers today. I'll introduce Dr. Ademola first. So Dr. Foluso Ademola is a child and adolescent psychiatrist with over 20 years experience. She completed her medical degree at the University of Ibadan in Nigeria and went on to take training in psychiatry and child and adolescent psychiatry in both the Republic of Ireland and the United Kingdom. Dr. Ademola is double certified in psychiatry and child and adolescent psychiatry with the Royal College of Physicians and Surgeons of Canada. Currently, she practices in the inpatient unit at the Royal Alexandra Hospital, as well as the Stollery Children's Hospital Psychiatry Clinic here in Edmonton. Her academic interests include anxiety disorders, psychosis, eating disorders, with particular focus on integrating psychopharmacology and psychotherapy to treat complex cases. She also does quite a lot of teaching as a clinical assistant professor here at the U of A in teaching medical students and residents. And outside of her professional commitments, Dr. Ademola enjoys reading, biking, and traveling when she's not busy multitasking for her 3 children and spouse. So Dr. Trishnee Chinniah is a child and adolescent psychiatrist who primarily is engaged in inpatient work at the Royal Alexandra Hospital, as well as the Rutherford Mental Health Clinic. She was born and raised in South Africa and has been a proud Edmontonian for many years. She completed medical school at the University of Pécs, Hungary, and also completed general psychiatry and child and adolescent psychiatry training here at the University of Alberta, followed by certification also with the Royal College of Physicians and Surgeons of Canada. And she also is actively involved in teaching and mentoring residents and medical students. And outside of the colorful work of child and adolescent psychiatry, Dr. Chinniah enjoys traveling, hiking, gardening, baking, and trying relentlessly to employ child psychiatry principles to raise her very smart, very naughty dog, Sophie. So we are delighted to have both Dr. Ademola and Dr. Chinniah to present on youth psychosis today. Welcome.
Thank you very much, Dr. Liang. Just to double check if everyone can see my slide. Okay.
We can.
Yes.
Awesome. And you can see the Oilers background as the Oilers fan that I am. Yeah, so I'm here with Dr. Chinniah, and we'll be talking on that topic of psychosis. Disclosures, both Dr. Chinniah and I do not have any disclosures on the following that have been listed on the slide. The objectives of this talk are as listed on the slide as well. And before we get into the, discussion, the talk itself, we were hoping to do like a pre-presentation quiz just for people to test their knowledge about a few different aspects of psychosis. So if Natasia can help us project that poll question. Okay. So I would like everyone to attempt to answer the questions. And at the end of the talk, we will also do a post-presentation quiz, and then you can see how you did. Okay.
Yeah, so the poll's on right now. I think you might need to scroll down to see all the questions. And if you can just enter the answer, and then again, as Dr. Felicia indicates, we can take a look later in the session.
Okay. All right. So I think we can move on from the poll. So I can change my slide. That's okay. We'll share the results later. Can we exit the poll, please? Just so that I can move my slide.
One moment here. Okay, there we are.
Sorry, say again?
Good now?
Yeah, I can't seem to move my slide on. Okay, there you go. It's working now. So psychosis. So psychosis is essentially an impairment in thought and behavior that is severe enough that the patient is unable to tell apart what is real from what's not real. It is actually a description of mental status. It is not a diagnosis. And the underlying pathology causing psychosis is quite broad. It could involve psychiatric causes or even non-psychiatric causes, which could be organic or medical. So in the DSM-5, psychosis is defined by different sets of symptoms. It could be one or more of the symptoms listed below. It could be hallucinations, delusions, thought disturbances, behavioral disturbances, which could include catatonia and negative symptoms. For hallucinations, these are perception-like experiences that could involve any of the 5 senses. They are typically vivid and clear experiences to the person who is having them, and it has the full impact of a normal perception so that the person who is going through it feels it is very real. Auditory hallucination is by far the most common in schizophrenia spectrum disorders. So if you have a patient in front of you and they are experiencing other hallucinations like visual, tactile, olfactory, you should consider ruling out organic causes, as that's likely to explain some of the hallucinations. In schizophrenia in general, hallucinations are more common than delusions. In terms of the mental state, which is really important, if you have a patient sitting in front of you, you can imagine if someone is talking to you, like 2 people talking to you at the same time, and you're trying to focus on that, you might seem distracted or irritated, you wanting someone to talk at a time, you might delay your responses, or you might say the wrong thing because you're not able to follow what one person or the other is saying. So this is how it is for people who are experiencing auditory hallucinations, or even visual hallucinations. They seem quite distracted, their latent responses, they are disorganized in how they speak because they are responding to internal stimuli. Delusions can also be a symptom referring to fixed false beliefs, which remain unchanged even though there is evidence to the contrary. It primarily refers to the content of the person's thought. One of the most common delusions is the persecutory delusions, where the person feels like they're being stalked or they're being harassed or somebody is out to get them. Grandiose delusions, believing that one has exceptional abilities. Capgras delusions, where the person believes that someone close to them has been replaced by an imposter. And even bizarre delusions, like something really impossible, like someone believing that a chip has been implanted in their brain. The people that experience delusions have it so fixed that they feel like there's nothing that can change their mind about it. They really believe that it's happening. You should observe. So if somebody is telling you that they are experiencing those things, you should observe their mental state for clues, see if they are distracted, see if they are behaving suspiciously, avoiding eye contact, not wanting to talk to you. Sometimes they're kind of guarded, and yeah, they might just be mumbling to unseen stimuli. So those are maybe clues in the mental state you should look out for. Negative symptoms are more likely when the person has been experiencing psychosis for a longer period. It could come in form of diminished emotional expression, decreased motivation, poverty of speech, loss of interest in social relationships, or inability to experience pleasure. The other one to be aware of is that some people with psychosis will lack insight and believing like they are not unwell. And this can be an indication of poor prognosis. So misdiagnosis is common in psychotic illnesses, because the dilemma for physicians is that when someone is in front of you and they say they are experiencing hallucinations, one of the first things you're thinking of, oh, is this person psychotic? However, to counter that, when hallucinations occur in isolation, it is benign most of the time. And some studies have quoted 15 to 20% in teens where they have, isolated hallucinations and they are not mentally unwell. Some young children also experience it with no evidence of mental illness. So accurate diagnosis needs you to pay attention to the person's mental state and to check if there's been any deterioration in their functioning, getting a good collateral from people who know the young person very well, like the parents or even the school, or even extracurricular activities will give you clues as to whether they've been abnormal behavior or a change from their baseline. So yeah, that's kind of, those are the things that you need to kind of keep in mind. Differential diagnosis. So like I said earlier on, there could be, for psychotic illnesses, schizophrenia, spectrum disorders. Some of the disorders don't meet full criteria for psychosis. For example, schizotypal personality disorder and delusional disorder. And some illnesses, they meet criteria for psychosis, like brief psychotic disorder, which is kind of short-lived symptoms, schizophreniform disorder, which is essentially like schizophrenia, but it's of a shorter duration, active symptoms 1 to 6 months, substance-induced psychotic disorder, or a disorder due to medical condition. And then schizophrenia, schizoaffective disorder as well. So there are some non-schizophrenia spectrum disorders as well that can present with psychotic symptoms. And they are the ones listed there, just so we're aware: bipolar disorder, depression, OCD, PTSD. We see that quite a lot in kids, grief and bereavement. And there are some non-psychiatric causes too that are medical. One of the most common ones we see in our unit is autoimmune encephalitis. So secondary to an infection, The person may present with psychotic symptoms. Your clue is most of the time is sudden onset, and they may have some neurological symptoms as well, and a history of, previous viral infection. Hormonal causes too are under the medical causes. In terms of epidemiology, early onset schizophrenia refers to if the person develops symptoms that meet criteria for schizophrenia before the age of 18. The thing to note about early onset schizophrenia is that it is clinically continuous with the adult onset, and it's more likely to be severe, respond poorly to treatment, and some of the patients will have developmental abnormalities if you do take your developmental history. Prevalence of schizophrenia is 1% worldwide, but for early onset schizophrenia, it's less at 0.5%. The peak age range for the onset of schizophrenia in adolescents is between age 15 to 30 years. And any, symptoms are very unlikely before the age of 13. So if you have someone in front of you who is, less than age 13, describing psychotic symptoms, the chances that it's a psychotic illness is much, much lower than someone who is an older teenager. Risk factors, big risk factor is genetics with, higher incidence in people who have first-degree relatives with schizophrenia. Monozygotic twins, 40 to 60%. Some patients, with the illness have no family history of psychosis. Environmental factors like, I discussed initially, infection, pregnancy and birth complications, in utero exposure to substances, childhood trauma, season of birth, like late winter and early spring, and advanced maternal age. Another big risk factor that we should be aware of for sure in this day and age is cannabis. Like that has been really normalized now, but it is a known and established risk factor for development of psychosis. And in terms of people being more at risk, it's more likely to be a risk factor if the young person starts to use early, if there's frequent and daily heavy use, if there's high potency THC involved, and synthetic cannabinoid is another risk factor. So at this point, I will happily hand you over to my colleague, Dr. Chinniah. Thank you.
All right. Good morning, everyone. And thank you, Dr. Ademola. So I'll continue now with a case discussion based on a case that was admitted to the unit. So we had an 11-year-old boy under PGO status since his father's sudden alcohol-related death 2 years prior. He lives in a high-needs group home. He has a history of intellectual disability, FASD, severe receptive and expressive language disorders, ADHD, and ODD. The concerns from the group home are vague and wide-ranging. They query conduct disorder, psychosis, or mania. The group home manager and psychologist believe that the youth becomes psychotic or manic every 6 to 8 weeks, lasting a few days, and spontaneously remitting. The validity of his existing ADHD diagnosis is being questioned by the psychologist, who is suggesting that the stimulants be discontinued. So feel free to use the chat function here. What questions would you have for the group home regarding the youth to help clarify the diagnosis? And I'm not sure if I can see the chat function, actually. Let me see here. No, it doesn't look like it. feel free to go ahead and think out loud to yourselves as well. Let's see here.
You know what? I think in the Q&A, someone mentioned that the chat is actually disabled.
Oh, okay.
Okay, it should be good now.
Okay. Okay,
Thank-
so I think maybe now it's good.
Okay, thank you. So in terms of mood symptoms, he would not have met the criteria for a DSM diagnosis of depression or prior manic episodes. In terms of anxiety or OCD, they say they have no worries about him having an anxiety disorder whatsoever. Regarding psychosis, they claim that he gets hyperfixated on animals and plants, that he often talks in a strange voice, that he often laughs quite maniacally. He says he can talk to wolves and his deceased father, which all began after a visit with an indigenous elder. He often appears in his own world and is just difficult to follow. Past medical history-wise, he's otherwise healthy. You can see his medication list here. Family history is significant for substance use disorders for both parents, with drug-induced psychosis for mom. His personal developmental history, so as mentioned, did have in utero exposure to substances. All of his milestones are delayed. He's had multiple apprehensions and placements starting as young as 3 weeks of age. He's essentially had the full gamut of abuse, from sexual to physical, emotional neglect. In review of psychiatric symptoms with the patient himself, he also screens negatively for depression or mania. Grief, however, is a significant concern. He struggles with sadness, anger, guilt when thinking about his dad. He describes that anxiety is actually a very big problem. It impacts his sleep. It leads to skin picking. Regarding psychosis, he endorses hearing voices, but they are transient in nature and really only after watching something scary. I don't know if any of you will remember this character Momo from YouTube a few years ago, but he referenced Momo. He would, in terms of speaking to wolves, he would hear wolves howling outside the ranch, and he would often howl back as a means to comfort them. He believed that their howling was an indication of sadness. Regarding delusions, he did make some odd comments, like, "Sometimes I think I'm cursed." When we asked him why, it seems that Dad would often say to him, "I can see the devil dancing in your eyes." He'd also overheard the group home staff calling him a bad seed. So taken together, he kind of led to the conclusion that, oh, I must be cursed. So his initial mental status exam, before making any medication changes, he was exceedingly restless. He almost fell off his chair. He crawls into the table, fidgets with any object within reach. His speech is childlike. At times, he switches his tone of voice, seeming to have an unintelligible conversation with himself. When he's alone in his room, he does in fact laugh. It is actually quite maniacal. I'd offer to act it out, but I don't want to worry the nurses here. When asked about all of this, he explains that he's actually quoting and mimicking his favorite Disney character, Maleficent. His thought form is tangential, distractible. When asked what's prompting the shift in topic, he's always able to provide a logical connection. Overall, those quotes, whether they're from Maleficent or another Disney movie, they do relate to the current conversation. His affect is easily tearful, angry when he's talking about his dad or trouble at the group home. Really, we don't observe any perceptual disturbances. So taken what Dr. Ademola has described so far, does this boy meet DSM definitions for psychosis? And if not, what diagnosis best explains his presentation? So again, please use the chat function to let us know what you're thinking. Or feel free to think out to yourself. So again, I don't see any answers coming in. Okay. If you were thinking of ADHD, intellectual disability, unspecified trauma or related disorder, an anxiety disorder, or bereavement, though not a DSM diagnosis, but a significant contributor, then your thoughts would be aligned with the treatment team.
Is a comment here about our recent talk about complex trauma, and I think that was mentioned in your differential diagnosis in terms of considering that.
Yes.
And then yeah,
definitely. Thank you. So with all of that being said, what is the next step, best step regarding medication management? And Natasha, will get you to pop up the next poll here. We're a bit tight on time, so unfortunately, I am going to have to go ahead and I see people are answering. Thank you. So far, the majority are right. Well, that is exactly what the team did. We did increase his Concerta. He was titrated up to 72 milligrams daily. And given the unclear indication for the olanzapine, he was gently titrated off. So his mental status exam after those medication changes, we saw significantly less psychomotor hyperactivity and impulsivity. His speech was not normal. He was stopping to think answers through. His thought form was still quite concrete, but he was able to provide a more linear response. There were no concerns for delusions at any point. His affect was still distractible. Sorry, I'm just trying to get rid of that. His affect was still quite distractible, but much improved. Again, at no point did we see him responding to hallucinations. So in terms of differential, I think Dr. Ademola did cover quite a bit of this, so I won't spend too much time. The main points to highlight: considerations to avoid misdiagnosis. So developmental context must be considered. Discussing psychotic symptoms is an abstract task and can be challenging in very young or concrete, impressionable patients. Young or developmentally delayed patients may feel pressure to provide an affirming response, so non-leading phrasing is quite important. As we saw with our case, the context of endorsed hallucinations must be considered. And finally, I think something we see clinically quite often, kids may learn that they can avoid negative consequences by attributing undesirable behavior to commanding voices that they might hear. So benign hallucinations, as Dr. Ademola mentioned, is very common. The main thing to highlight is that they do not impair functioning. Same thing with imaginary friends. I think we're all quite familiar. It's a common phenomenon. It is normative, though, and thought to help with development of social emotional regulation. Once again, not impairing to functioning. Cultural and religious considerations. So symptoms that may sound symptoms that sound psychotic in nature might be a normal phenomenon in certain cultures. So that context is very important. With bereavement, as we saw in our case, youth may report auditory or visual hallucinations of a deceased loved one. If these are neutral or comforting, this is less concerning. Any distress would indicate a need for intervention and therapy. Really briefly here, because it does pertain to our case, both intellectual disability and autism to some extent, there may be endorsed symptoms of psychosis, which again might represent fantasy, imaginary friends, or self-talk. Notably, a stressful event can trigger a transient psychotic episode. However, once the stressor is over, those symptoms resolve spontaneously. Co-occurring schizophrenia is really only considered when there's a significant change in functioning and overt delusions or hallucinations. I'm just going to skip through those. I think something to highlight, particularly in this day and age, an important consideration, particularly in the impressionable youth that we work with, is social media contagion and consideration for factitious disorder. So anytime we're seeing eager, dramatized, exaggerated descriptions of symptoms, use of jargon, this would raise suspicion for a factitious presentation. Just to highlight, as Dr. Ademola pointed out, by definition, psychosis is a loss of reality testing. That's quite distressing. So what is the advice to generalists or pediatricians who encounter a patient with vague symptoms and mild functional decline? When only one symptom is present, consider referral to a therapist for evaluation and monitoring. If there are multiple symptoms, this is probably best served with referral to a therapist and consultation with child psychiatry. In terms of potential preventative measures, these are likely limited to cannabis use or other substance use disorders, as well as good public health measures, such as good prenatal care, general pediatric care, including immunization. This is just a helpful guide. The low-risk cannabis use guidelines can be helpful talking points for a brief intervention. In terms of assessment for first episode psychosis, so examination should include a neurological and detailed physical exam. You can see a wide list of laboratory investigations here. In terms of EEG, LP, or imaging, that's done more on a case-by-case basis. I think the main thing to highlight here is that neurocognitive assessments are, though difficult to attain, are very important for documenting cognitive deficits, as well as for treatment and academic planning. A good second choice would be psychoeducational assessment, just to kind of gauge where a kid is at. Assessment of suicide risk is quite important. So we know that people with schizophrenia do have an elevated lifetime risk for suicide, up to 5%. There are a number of identified robust risk factors, including a prior history of depression, previous suicide attempts, substance misuse, poor adherence to treatment, and in terms of assessment of risk of aggression. Similarly, there's increased risk associated with comorbid substance use. We do know that antipsychotic drug treatment substantially decreases this risk. And with that, I'll hand over again to Dr. Ademola.
Thank you, Dr. Chinniah. So I'll talk quickly about the pharmacological management of psychosis. So for first episode psychosis, recommendations will be to urgently refer all children presenting with sustained psychotic symptoms lasting 4 weeks or longer to a child and adolescent psychiatrist for further assessment. If you as a generalist or pediatrician feel you should be starting an antipsychotic, it should be done in consultation with a child psychiatrist. So this is a big table, list of various antipsychotic medications that are FDA approved for treating adolescents with schizophrenia. As you can see from the table, most of the medications are approved in age 12 and up, but we do use them off license for off-label for kids that are younger if it's indicated. The dosages are there for starting doses and maximum doses. Of note, children and adolescents are more sensitive to antipsychotic side effects, so it's very important that we are maintaining low doses to start and then to increase very slowly. Antipsychotics have to be given in conjunction with psychosocial interventions. The evidence has shown that it is also quite effective in children and adolescents like it is in adults. And there is no evidence that one antipsychotic is more superior to the other, except for clozapine, which separates out of all the others and is used in treatment refractory cases. For adequate trial, you need to be sure that the patient has been prescribed the antipsychotic at a therapeutic dose for at least 4 to 6 weeks, and not to combine antipsychotics except maybe during switching medications. In the post-acute phase, for maintenance treatment, patient has to remain on antipsychotic medications for 2 years as part of their maintenance treatment. Parents and patients have to be informed that if they do stop the medication earlier, they run a higher risk of relapse. And even when the antipsychotics are discontinued, it's important to monitor closely for at least 2 years. In terms of managing relapse, long-acting injectables are recommended. At the moment, in child and adolescent population, it's off-label, but there's good evidence in adults that it helps to reduce relapse, it improves compliance, and even introducing it early in the treatment will enhance uptake and acceptance of that treatment from patients when it's introduced early on. The other thing we use to support treatment and to reduce chances of relapse is community treatment orders under the Mental Health Act, which ensures that the patients get their treatment in a timely manner, and that if they were going to default, it will be caught earlier on. And there are times we do involve our family physician colleagues to monitor medications and to give the injections in their practice. All right, I will hand you back on to Dr. Chinniah.
Okay, thank you, Dr. Ademola. So in terms of psychosocial treatment, I think the main thing to highlight here is the patient and caregiver education. And this can be regarding the nature of the illness, the importance of adherence, symptoms of early relapse, and substance use. Even though per the schizophrenia guidelines, there's no evidence for significant impact on outcomes, we know that it is important for empowerment and informed consent. Clinically, I think Dr. Ademola will agree, we do find that this is helpful, particularly in the pediatric population where caregivers are able to supervise. In terms of the next thing to highlight here, so supported employment and supported education programs are, I think, the biggest takeaway for psychosocial intervention. Employment and education are essential domains of recovery. Any clinician can support with this. The guiding principles, just in summary, include a goal of enrollment into regular schooling and or competitive employment, zero exclusion, meaning that supports should be accessible to all, and the clinical team can work closely with programs to ensure there's a rapid return to school and work when the patient is well, and that accommodations are negotiated. And that actually brings us to the end of our talk. I think we were going to have some housekeeping done by Natasha here.
Thank you. So I think we're gonna put up, you were gonna do the quiz, all right? Or
Yes.
Yeah, we could do the quiz next.
Yeah.
so just a reminder that these rounds are accredited by the Royal College of Physicians and Surgeons of Canada and also the College of Family Physicians of Canada. And then I think we wanted to put up the evaluation slide while we move on to the Q&A. And then I appreciate that because we're finishing up at 11:40 a.m. today, that you left enough time, because I do see that there's some comments and questions in the chat as well as the Q&A. So how would you like to do this? Would you like to do your like talk about your poll first, and then maybe move on to some of the comments and queries in the chat and Q&A?
Sounds good.
That makes sense.
Yeah.
Natasha, are you able to put up that final poll for us?
Okay. I think participants have to actually choose their answers, and then we display the results. Thank you. Yeah, I think we can split the results now and
Yeah.
yeah, do you want to speak to any of them quick?
Sure, yeah. So for the first one, yes, B is the right answer, that it's 15 to 25% that are assumed to have hallucinations that are benign variant in teens.
Yeah, the most impairing symptom in schizophrenia is the negative symptoms because it significantly affects functioning, like even ADLs, going to school, interest in things. So negative symptoms is the answer to that one.
And for number 3, which statement about early signs of psychosis is true? And that would be B, that early signs may include social withdrawal and more academic decline.
Okay. And then which of the following is true about the onset of psychosis? Wow, everyone got this right. We didn't have any mixture of answers. Onset prior to the age of 13 is rare. So that's correct answer.
Yeah, that's exactly right. Yeah.
Okay, and we can take questions whenever we have the go-ahead, Dr. Leong. Thank you.
Sure. Actually, how about we go with okay, maybe first of all is in terms of the copy of the PowerPoint, are you okay with sharing? Because there's a lot of information presented and it sounds like some people wouldn't mind having a copy.
Yeah, that's fine. Yeah.
Okay, super. So maybe we'll go with the chat in terms of because I think going back to yeah, some of the comments were to your earlier questions. So okay, maybe we'll go back to Q&A here. Any theories on why season of birth is a factor?
I think I discussed that one. Yeah, season of birth, there are a few theories. One main theory, again, like I said, it's like a winter and early spring. That is like the flu season. So that's one of the theories, that because people are more likely to get influenza, it also can affect fetal brain development, the immune system. And so that's the theory on that one, just the high incidence of viral infections during that season. The other possible explanation that has been provided is some deficiencies in terms of nutrition, and also something like vitamin D, which is kind of low during the winter season. And vitamin D also promotes fetal brain development. And so that's kind of one of the explanations about why it may be a risk factor.
Thank you. So the next question is there any evidence that treating with higher doses of antipsychotics in the acute phase is beneficial?
I'll go first. I'll give it a stab. I don't know that there's evidence per se, but that being said, in the acute setting, when someone is acutely psychotic, we are often needing to use higher doses in that acute phase that might then allow for quicker stabilization. We know that untreated psychosis left over a longer duration has poorer outcomes in terms of treatment. Typically, when people are in the maintenance phase, they might tolerate a lower dose. So it doesn't exactly answer your question. But that's probably my best answer that I can think of. Yeah. I don't know if Dr. Ademola, you have any thoughts?
Yeah, no, I agree. Higher doses is not necessarily better per se, but we tend to, in acute settings, use high doses because we can monitor. High doses carries risks, so you can't do that readily in the community. Like I said earlier on, young people are more prone to dystonic reactions and extrapyramidal side effects. So we have to be really gentle with doses outpatient-wise, but inpatient, we can load up with higher doses to bring the symptoms under control. Plus, we need to control aggression, have them sedated, have them sleep if they are not sleeping, all that.
Yeah.
So yeah, high dose is not necessarily better, but it can be used in the acute phase in an inpatient setting. And then we switch to something more tolerable for maintenance.
Yeah. Yeah, I think the old adage of the lowest effective dose, it still rings true for pediatrics. Yeah.
Thank you. And we have another question here. If I may, how often or are organic vision-related differentials seen, like the Charles Bonnet syndrome, or a more profound astigmatism or low vision?
That's a very good question. I think we probably don't see a ton of that on acute inpatient. I'm guessing that those are the kids that show up to emerge. And if a psychiatrist is being consulted, they're probably redirecting that to the more appropriate specialties for vision, for example. But we don't see a ton.
No,
Yeah.
no, we don't see a ton of that. We tend to see, we've seen cases of encephalitis, NMDA encephalitis, that present with psychosis, but not those kind of conditions.
Dr. Mark Nicol, it might be helpful. Oh, so maybe you can mention the role of the Stollery Child and Adolescent Psychiatry Consultation Service.
Are you asking us?
Yes.
Okay. Yeah, for the Child and Adolescent Liaison Service, I'm aware that they work in conjunction with the pediatricians at the Stollery. And most of the time, if a patient is admitted, sometimes they do consult us. And depending on how they present, if we think there's a strong organic basis for their presentation or feel they need intensive workup, we recommend that they are admitted under pediatrics and involve the consultation liaison psychiatrist and a neurologist, especially if we're thinking something like encephalitis, and they can do EEGs, LPs, and do a full neurological exam. And while involving the neurologist, the CL team also see the patients just to make sure that they are supporting and they are doing a full mental state and providing recommendations on treatment. And once all that is done, there are still cases where all that is done and they still then send the patient to us, to the child psychiatry unit here at the Realic.
Yeah, I think we're that, like we always have an acute child and adolescent psychiatrist on call. And so if you're not sure, or you think maybe this is an acute psychosis, maybe the kid needs an acute assessment, just call the switchboard of the I guess the Stollery Hospital / University of Alberta Hospital. So then you can talk to the acute care psychiatrist, child and adolescent psychiatrist on call, and then I guess they can, have the heads up if you are seeing your kid, sending your kid to the ED for a possible admission. So, because I think you did emphasize in your talk that we should be treating acute psychosis early. So I think if people feel that there is a true acute psychosis, we do want to hear about it and stream them into our system. And there's some comments in the chat here and questions. So can you speak to any experience with the newer medication like Cobenfy, which target cholinergic receptors rather than dopamine receptors? Although there's a further comment that that medication is not approved for use in Canada yet, but I guess maybe just the general class of medications that might have a different target than dopamine.
That's a very interesting question. I personally don't have a ton of familiarity with that medication. In the pediatric population, we tend to try and use medications kind of like in the geriatric population that have been around for a while and have had some time to kind of see evidence of effect and evidence against really detrimental side effects. So probably not something that I think most child psychiatrists are using as yet.
Yeah, and I don't have additional information either about that.
Yeah, and I think Dr. Marino De Luca put up a web link to a meta-analysis showing that dose equivalencies for a number of different antipsychotics, at which 95% of people with schizophrenia respond to what those doses are. And yeah, that there's a comment that, as you mentioned, that there is likely very little benefit going beyond those, the dose where 95% of people do respond. One of the questions I had when you were presenting is, you had mentioned that delusional disorder is not considered a psychotic disorder. And then at a different point in your presentation, you said that delusions are considered a form of psychosis. So I just wanted to, for you to comment on that, maybe.
Yeah. So maybe it's the way I explained it. So delusional disorder is not a schizophrenia spectrum disorder, was what I meant to say.
Okay, that clarifies it more, because I think I was thinking, well,
About that.
yeah,
that's what I meant to say.
All
it's
right.
not schizophrenia spectrum disorder.
Okay, all right, yeah, so they would still be considered a psychotic disorder, just not schizophrenia spectrum.
Yeah.
Okay, fair enough. Oh, I guess Dr. Brent Harold said it is important, though, that there are 5% who need higher doses. Do you ever do like genetic testing? Like, I'm just trying to think whether like the pharmacogenetic testing for people who might have like another genetic, like a different threshold for some of the medications.
Not routinely. I don't do it routinely in my practice. I don't know about yourself,
Yeah.
but it's not something we routinely do.
But I can see it being helpful if someone has had a number of trials and isn't having expected effect.
Yeah, good point. Dr. Nicole, did you want to come off mute to talk?
Yeah, thank you, Dr. Leung. Dr. Chinniah and Dr. Ademola, thank you very much. Sorry, my view is messed up and I'm getting confused easily. Thank you very much. This is really timely and relevant for all of the therapists out there in the community clinics, because and I just thought I would check a few things with you, because sometimes, I'm a clinical supervisor, and so a newer therapist might come to me and say, this 15-year-old is hearing voices. I think they need to see a psychiatrist. And what I like about your presentation is it sort of gives us some more things to focus on and to get curious about. So if I'm correct, is it fair to say that we want to be paying attention to the big picture? And if this 15-year-old is coherent and sitting in front of me and saying, yeah, I hear voices, but I'm not seeing any of those other signs and symptoms that you've mentioned, it's not a 5-alarm fire. I don't need to go rush and make a psychiatry referral. If I see coherence, if I see, people, they aren't reacting to those stimuli, the external stimuli, I can take my time and sort of get to know them, and then see where that takes us. And then if they're under 13, it's even way less likely, because we get these kids that 15 to 25%, I think, is a great stat, that they'll have that experience, but they aren't psychotic.
That's an excellent summary.
Yeah. Thank you, Dr. Nicole.
Okay. Okay, thank you. That's helpful for all of us. Appreciate it.
Yeah, quite reassuring. I had a case once. So there was actually a 15-year-old kid who had all the textbook symptoms of schizophrenia, basically rattled them off during an interview to a psychologist. And the psychologist prepared a report to say, you have schizophrenia. And I had been seeing this kid for 2 years, and they came to me, rattled the same symptoms, but mental state-wise, they were coherent, they were logical, there was nothing else going on. They were still attending school, and they were the best I had seen them in 2 years in terms of
Yeah.
functioning. So I said, you don't have schizophrenia.
Yes. Yeah. Yeah. No, really helpful. Thank you very much.
Really helpful to contextualize. Okay, we're almost at the time here. So I guess maybe a quick question about methamphetamine-induced schizophrenia form diagnosis in youth, and if this makes them vulnerable to experiencing or developing schizophrenia later.
It's a very good question. I think looking at a substance-induced psychosis, and I think I'm speaking colloquially, but also looking through the lens of what we know about cannabis-induced psychosis, that once someone has used substances to the point that they developed a psychotic episode, any recurrent use is going to increase the risk of further psychotic episodes. And then that can have kind of a kindling effect, and you can increase your risk, you know, if you're going a longer period of time without treatment, of developing a more chronic psychotic picture would be, I think, the best way I can answer it. And I don't know if Dr. Ademola had any thoughts.
Okay, we're out of time. There's another question about Clopixel and managing aggression, but I don't know if you can say it really quickly.
Yeah, Clopixel, as in like, I'm guessing the person is referring to Clopixel Acufase. Yeah, very rarely we use it on our units. When we've tried other agents like haloperidol, or even benzos like lorazepam, or even olanzapine, loxapine. So yeah, there have been rare. I don't use it much myself, but in my in the unit here, sometimes we use it. It doesn't always work though in young people for some reason. Yeah. But it is an option if you've tried other agents. It's not contraindicated, it's off-label, but sometimes we have to go to that if nothing else works. Don't know whether.
Yeah, I would agree.
Yeah.
Okay, so but thank you very much for a very comprehensive presentation, and lots of interaction as well, and so thank you very much for this wonderfully engaging presentation.
Thank you, Dr. Leong. Thanks, everyone.